Because I'm from New York. This chapter I broke into 3 chapters a couple of years ago, and we gave it over 3 different months because there's so much to learn. Lately, you guys have been doing such a good job on your presentations. I'm going to kind of skim through some of this because a lot of the retinal vascular diseases we're going to cover in conference because you'll get cases. And feel free to bring your own cases, although I do like the control, because when I send you a little bit of control issue, when I send you cases, I can sort of look at what's been presented. So over the course of 2 years, that's why sometimes you get goofy ones, like Nabil got one just on drusen today, which I think is kind of fun. So we can cover things like vein occlusion, but also sort of stupid stuff. So this is a chapter on retinal vascular diseases, and hold on a second. Yes. There you go. So this covers a lot. It covers hypertensive retinopathy, retinal vascular occlusions, which are branch vein and central vein, and branch artery and central artery, carotid occlusive disease, kind of briefly, because you don't see it that much. And then also arterial macroaneurysms, we talk a little bit about, even though there's not that much to say. But again, this is stuff we've already talked about this year. We'll definitely talk about in the future. So hypertensive retinopathy. One of the fun things about the retina, I think, is that the retinal vessels auto-regulate. Auto-regulation, I'm not going to be super interactive, we'll be interactive later. Auto-regulation, as you'll recall, is it's set up it happens at the pre-capillary arterioles and capillaries. The choroidal vascular does not auto-regulate, retinal vasculature does. It dilates and constricts the vessels, and the idea is to maintain constant flow to the organs. So what will happen is, if your blood pressure goes up, what does the vessel have to do? You can answer this. Constrict. So if your blood pressure goes up, it has to constrict. If your blood pressure goes down, it has to open. They also auto-regulate, the retinal vessels also auto-regulate for oxygen, which is kind of cool. So if oxygen level goes down, what does the vessel have to do to deliver more oxygen? So it has to open. Thank you. So that's why when you look at the retina and you see the vessels constricted, that usually means they're seeing higher oxygen tension. And if your blood pressure is up, they'll constrict too, and that gives you all these findings. And then the other thing that's in the text, I always like some things out of the book. I strayed from the book a little bit just because I was getting, I don't know, I felt we should have something new and interesting in. But one thing that's in the book is focal arterial narrowing and arterial venous nicking have little predictive effect for actual blood pressure. So if you see it, it doesn't mean their blood pressure is high or low. It just means they're either a vascular path, but we do call it hypertensive retinopathy. As you move into practice, one thing you might want to do, which is what I do, is I have hypertensive retinopathy in a lot of my charts because you can code for it and you can charge for photos and scans. So I have like grade 1, grade 2, grade 3, grade 4, and I have a little explanation. And so if you take a photo, because a lot of times we take, it kind of rots. If you're seeing a diabetic, you really have to scan and picture all of them, but you can't charge for it if there's no findings. Medicine's geared toward findings, not toward screening. But anyway, everybody has something in the retinas. So grade 0 is normal. Grade 1 is just a little bit of vascular narrowing. Grade 2 is our obvious narrowing with AV nicking. Grade 3 is grade 2 plus retinal hemorrhages. Grade 4 is grade 3 plus optic nerve swelling. And that's something of an emergency. So this is grade 0, I think. There you go, normal. And so the ratio, if you guys off the top of your head, the arteriovenous ratio you're supposed to have, the width of arterial with the vein.
2/3.
2/3, yeah, it's 2 to 3. So it's supposed to be 2 to 3. And this is about 2 to 3, so you'll read a lot about, you'll read some about silver wiring and copper wiring. I mean, these do look a little bit silvery, but these are pretty normal. This is actually equatorial drusen, but that's not why it's here. It's because there's a little bit more narrowing of the retinal vessels. So this is a little bit more of a grade 1. If you look at these vessels here, there it works. Here, that's a little more, I think, of a 1 to 2. So I call this a little bit narrowing. Okay, didn't talk too much. And then this one has a finding up here where you can see the artery nicks the vein a little bit, and here it nicks a little bit too. So this one would be grade 2, obvious narrowing with focal irregularities, which is AV nicking. And then here you got hemorrhages. So this is a patient with that. Now, when you see hemorrhages in the retina, anytime you see hemorrhages, you think diabetes, but if you're past diabetes, you look for a vein. If they're in the distribution of a vein, it's always branch vein. Vein occlusions are super duper common. It's the second most common retinal vascular thing we see. So if you can find, like I had a really good case yesterday, I'm going to bring in such an obvious vein occlusion. This person, if you look at the hemorrhages, they're not in the distribution of a single vein. And there's some cotton wool spots. There's not a central vein occlusion. So it's, and the blood pressure was high. It was grade 3. So this is hypertensive retinopathy. You got the arteries are narrow, the veins are funny looking. You got AV nicking. You can see it down on the bottom of the slide, and also over by the nerve on the top. And then you've got retinal hemorrhage and cotton wool spots, but the nerve's not swollen. So grade 3 hypertensive retinopathy. And then grade 4 is when the nerve's actually swollen. So this person comes in with swollen optic nerves, hemorrhages everywhere, cotton wool spots, 204 and 167 are the nerve fibers. So that's grade 4. So also, everybody has automated blood pressure cuffs now, and they don't always pick up high blood pressures just because they're not smart enough. They probably will be in the future, I guess. But the other thing is, if you have one in your office when you get older, the cuffs have to be switched out probably every 6 months. They go bad. So if you have one that's been running for years and years, I gotta make sure we do that. We're supposed to do it, but things change all the time. So, and this was someone who was sent to me, referring doctor said the blood pressure was a little high, but he didn't know what was wrong, but the retina looked funny, and there was nerve swelling, and then the automated blood pressure was 150 over 90, and then I checked, it was 220 over 150. So the machines can be way off. So if you see something funny looking, just check the blood pressure yourself. I've done that several times in the past, and you'll find the blood pressure is very high. I had a case when I was in residency, fellowship, Bascom Palmer, where a young girl was sent in, because the kids can have hypertensive retinopathy. You can look crazy. I don't know if you've seen any of those, but I had a 13-year-old girl sent in, and the referring doctors with hemorrhages and nerve swelling. And the referring doctor called me and said, yeah, the vision's bad. There's all this stuff. I don't know, it might be like AIDS or something. And so I just said, check the blood pressure when she gets in. It was through the roof. And so she had hypertensive retinopathy. So you can get it as a young person too. And it looks a certain way. So when the retina looks a certain way, it's interesting when we can talk a lot, but when you see something funny looking, there's not a lot of diseases you haven't heard about. There's probably almost nothing you haven't heard about, or you can't just Google. It's interesting at these international meetings. Sometimes somebody comes in with a case from Brazil or from the Congo, with funny looking white spots, and it's always West Nile virus, or it's always toxo. It's just not, there's very few things out there you haven't seen. So if someone's got funny looking retinas, it's going to be probably something, Hypertensive choroidopathy is a little more interesting. Typically it's young patients, acute severe hypertension. The choroid's lobularly perfused, and you can get these little pigment spots afterwards. We're gonna have a case of that later, so just remember that picture. Somebody can get this case in the next couple of months. I had a good case coming recently, and I call these Elschnick spots, but these are actually Segrist streaks. Even though they don't look like streaks, they look like spots. So if there's little spots kind of following the choroidal vessels, like in this picture, those are actually considered Segrist streaks. I'm 90% sure, because I've looked this up so many times. But anyway, just Elschnick spots and Segrist streaks. And you can get RPE detachments in cirrus. So this is a 48-year-old woman. She saw a flash in her vision. Vision was good, and she comes in with just a cirrus retinal detachment. So if you look at the pictures, there's a leaky spot, and then you look at the OCT, there's subretinal fluid, there's a little choroidal thickening, and it was hypertension. So a lot of times in my central cirrhuses, I always make sure we check blood pressure. And I find it interesting, and I've never seen it written anywhere, and I always thought it would make a good article if somebody could figure it out and write the article. One of your residents wants to do that. Why sometimes hypertensive retinopathy manifests in retina, sometimes it manifests in the choroid. And I'm not sure why, because this person has no retinal findings. So you look at the retina, the artery does look kind of funny, doesn't it? Looks like there's plaques there, but there's really there's no hemorrhages, there's no disc swelling, there's no nothing, and then you get this choroidal swelling.
Do you know what the blood pressure was on that?
Yeah, this one was 165 over 120. When the blood pressure goes down, the cirrus detachments go away. So you get a hypertensive choroidopathy, and then you get a hypertensive retinopathy, and they're different. Okay, so that's hypertension. Any questions on that? We're going to keep going. So retinal vein occlusion is a huge topic. It's interesting. We always talk about, I've heard you guys mention, I've looked it up periodically about branch vein and retinal vein, branch vein and central vein, and their diabetes is a risk factor for one but not the other. And I think it's been an opto question. You guys have said.
Always.
If you look at the book, though, there's a 2023 update to the Academy book, and it just lists diabetes as a risk for both. So so if they give the question, I don't know what you want to say. What is it? It's a risk for central CRVO, but not for branch vein. But it was interesting. 2023 BSCS just says diabetes is a risk for vein occlusion for both.
So what's the answer on the test?
I think it would be, you go by the latest BCSC.
That's what I think.
You know,
So I think you gotta watch it. And I think they probably wouldn't ask it. You know, if you're doing a good test, which I think they do, they validate the question. So that's a question they would put on as a test question, but it won't count it and see what people answer. And then eventually they see if the question goes to the quiz. So just a weird thing, just to stretch it out a little more. All right, so retinal vein, the venous system can fix itself. You can get collateralization of the vessels. This might be some good time to get in. Oh, can you please send a resident out to let me in the conference room? That's not great. Thanks. So branch vein occlusion, you can develop collaterals on the horizontal FA. Central vein, you can get apostolic shunts, so they can fix themselves. I often explain to the patient, like if US 19's broken down or 275's got an accident, people can go on the side roads. So your venous system works that way. And then what you see is 4 or 5 years later, sometimes those side roads break down and you need treatment. But for the most part, it works. Branch vein, you know, is an obstruction in AV crossing. A lot of people don't talk about this, but the other thing you can get a branch vein is from focal inflammation in the retinal vein. Hey, how you doing? Good morning. Nice. Thank you. There's happy Hanukkah. Look at
Usually wearing like a full suit. So this is
EGH for that.
different.
This is my pharma consulting book.
Oh, nice. So if you look at this fluorescein angiogram, there's a vein occlusion that kind of comes off the optic nerve, but there's also a hot spot on the vein. So when there's a hot spot, and I don't know if you guys even talk, well, we talked about this some in conferences and meetings, but if there's a hot spot on the vein, you see it in about, I think, 10 or 20% of vein occlusions, and it's thought to be inflammatory vein occlusion, which you can get. So pre-anti-VEGF, there was a branch vein occlusion study, which we talk about all the time, even though I think it's barely relevant. But that's where if you have more than 5 disc areas of ischemia and a branch vein occlusion, that's considered extensive. And this is on the old photos, which we don't take anymore. And 30% of those patients had neovascularization, 60 to 90% developed vitreous hemorrhage without laser. So if there's extensive ischemia, you're supposed to do a laser there. This is non-perfusion. So we often talk about, a lot of times, like we'll show diabetics, and we had this happen, I think, 3 months ago, where someone looked at the pictures and saw that, oh, that's you again. I get it clear. This gives you 2 beeps. Somebody looked at pictures and said it was non-perfusion. So sometimes you look at the periphery of a picture, it'll be dark, and that's not really non-perfusion. This is non-perfusion. So you see your arteries and veins all are okay, but then on the bottom of the picture, which is here, you can see this dark area, and that's all the capillaries are gone. So this is a vein occlusion. Hemicentral vein occlusion is severe non-perfusion. Somebody might want a laser. In the VRVO study, they had permanent vision loss occurred mostly from subretinal fibrosis, epiretinal membrane, macular ischemia, macular edema, lipid endophobia, and tractional detachment. And again, this is all pre-anti-VEGF. This is an interesting case I use all the time for drill. It's my best drill case for disorganized retinal inner layers. So if you saw this patient only in 2018 on the bottom, I would look at that picture, because we often do this, because people ask us, you know, should I have my cataract surgery? Why is my vision bad? The cornea is not right. We're looking at the retina, we're trying to figure out what the vision would be. So when I look at an OCT scan, I look at the external limiting membrane, and I look at the nerve fiber layer, and I figure if those are both pretty good, the vision should be pretty good. So in this case, the external limiting membrane actually is almost intact across, and it's not great, but it's not bad there in the middle. And then if you look at the nerve fiber layer, it's robust. And then if you look, so I would think this eye would see maybe 20/80, you know, or 20/60, but it's actually a 3/200 eye. And that's because the middle retina is just shot. So in cases of severe edema like that, when the edema goes away, you still don't see because all your connections have been kind of truncated. So you can get disorganization of the retinal layers. You know. So laser for branch vein occlusion, and the branch vein occlusion study was shown to be a little bit helpful. You want to have an intact foveal vasculature. The vision was 2040 to 2200, so that last patient would have benefited. And then if there's non-perfusion, you want to treat the area of non-perfusion. So this is one of the times when we actually look. This is a 62-year-old patient I saw, had laser for vein occlusion 4 years ago, still getting a vitreous hemorrhage. This is the eye. You can see the pre-retinal hemorrhage. And then she's got neovascularization, which we don't see commonly in vein occlusion, but you do see it. So there's a nice looking neovascular frond. And then you do the fluorescein, and what you'll see is she's got the peripheral laser, which is probably although I'm the laser that light, but the laser spots are supposed to be at one spot apart. So when you're doing pan-retinal laser, you're supposed to do one laser spot between each spot. It's supposed to be pretty heavy, and this is awfully light. But then also in vein occlusion, you're supposed to laser most of the area of the ischemia, non-perfusion, and this is just not lasered. So there's a bunch of non-perfusion. The other hint to neovascularization is it tends to occur kind of in the right, sort of pointing toward the non-perfusion. So we just had to add more laser. So this was the ischemia. So I added more laser over here on the bottom slide, and you can see the neovascularization shrunk. Dr. Paven mentioned last time that if PRP is a 6-shooter, I think he said, then anti-VEGFs are like an atom bomb for getting rid of neovascularization. So PRP doesn't usually get rid of neovascularization, but it controls it. I mean, we know that from all the old studies. So even though you can inject this person with anti-VEGFs for the rest of their life, every month, you could also do a pan-retinal laser and let them go home and live their life.
One thing that I think is interesting is, a lot of people use the FA, and when you PRP someone, don't expect that the FA doesn't leak anymore, right? They still have, their NV is still there. And so you kind of have to use like hemorrhages or worsening NV. You watch the photos over time. You can't just say like, oh, I PRP'd and the NV is still active. So, I need to do something else to treat. This just doesn't do it.
Right, that's exactly right. That's true.
Yeah, and there's never been any studies. If you look at the old diabetic retinopathy studies, they were all about laser reducing the risk of vision loss in eyes that have not had laser. So there's never been a study of what to do if someone's had laser. And so it's probably because of that.
If they hemorrhage after they have good PRP, then I usually give them, intermittent injections, but I don't know.
We're getting better at that. In the clinical trials, we term these things now VTCs or VTEs, vision threatening complications or vision threatening events, which are usually vitreous hemorrhage, new onset DME, or anterior segment neovascularization. So don't just treat it because there's NV that's leaking, but it has to be a proliferative diabetic retinopathy event that's new. Otherwise, like Dr. Crane just said, you inject these leaky angiograms forever without necessarily giving any benefit over the PRP. How many of you guys understood that? Did any of you guys understand that? Yeah. Okay, all right. That's kind of a getting deep retina thinking what we're talking about here. But we're trying to confer some of that, but I know it's not cataracts.
You have so much to learn. I mean, you're starting from scratch. It's a challenge. You got a lot to shove in your head.
Yeah.
I read, it said in the 1950s, medical knowledge doubled every 50 years, and then in 2000, it was doubling every 3 months, I think. So you got a lot to learn, and the residents have to learn that.
So we're sorry if we do that sometimes.
Just stop doing research.
Yeah.
It's also nice because on so many patients, like, what are the get injections all the time? Are they like, so I'm gonna need injections for the rest of my life? And it's nice to like hear sometimes that like that might not be the case. Like there's situations where that's not the case.
But the short answer for those patients is yes.
Yeah,
Yeah.
but
But
here
it's
sometimes it's,
nice
there's
not to.
other
They
considerations.
definitely do better if they keep getting shot.
Yeah. So central vein occlusion, dilated tortuous veins, hemorrhages in all 4 quadrants, and optic disc edema. It can be subtle. So if you see hemorrhages in all 4 quadrants, you're thinking, oh, it's kind of funny looking. There's hemorrhage in all 4 quadrants. The veins aren't that dilated. The nerve swelling is helpful. So all central vein occlusions have disc edema. So if you want to scan the nerve, it's a little swollen, it's a central vein occlusion she'll say. So there's not ischemic central retinal vein occlusions, partially perfused, good vision. No or mild APD, and then ischemic central vein occlusions have they're non-perfused, at least 10 disc areas. This is the old studies, poor vision, APD, and in the central vein occlusion study, only 10% of patients got 2400 or better. So most in the old days, and this is pre-anti-VEGF, most patients with central vein occlusion didn't do that well. Intermediate, if someone's in between, 80% of them can progress to ischemic. So if you do have a vein occlusion that's doing well, you can't just say your vision's good, go home. I typically see them back, usually periodically for a year, not constantly, and I'm probably see people less than everybody else, but if, like, I had a guy with a branch vein, an 82-year-old guy yesterday with a branch vein occlusion, supratemporal macular branch vein occlusion, 20 asymptomatic, with hemorrhages everywhere. And his vision was good. But the thing is, I said it's superior, I think statistically there's probably a 20 to 30% chance he's gonna need treatment, it's gonna worsen, but not necessarily. So I bring him back. Central vein occlusions are a little more sinister because you can get neovascular glaucoma. So basically, if they're seeing well with the central vein, you still need to check them back to see if they're gonna convert to a worse central vein.
Let me ask you,
Antonio.
let me ask your guys' opinion. I had a guy, and something related to this, I had a guy who I saw in the hospital consult initially, a 50-year-old guy. He's blind from a terrible ischemic CRVO. I stopped shots on him 6 months ago and he came back literally yesterday. So I shot an FA, see what's going on. And there's literally little like ischemia and little NVs everywhere that are cropping up.
Mhm.
Would you PRP that guy?
What's the vision?
Hand motion since I met him. Looks a lot better after the shots, pale nerve.
Hand motion, I tend to hang on to. Once they're NLP, I call it a day and I stop everything. I don't put in, you guys can do what you want. I don't put NLP patients on any phone drops. I don't think that's right, but a lot of people do.
Wouldn't there be a risk of developing NVG? And
That's why I started PRP on him, because I don't want to commit him to the shots forever. He's hand motioning, he's happy to do whatever I want him to do, so I decided I was gonna PRP him over like 2 or 3 sessions.
I have an ocular ischemic syndrome lady with hand motion or light perception in one eye that I'm still injecting every 3 months. Because if for other eye goes blind, I don't know. Letting an eye go that sees, if something happens to the other eye, then they don't have anything.
Yeah.
But once it loses vision, it's different. So I would treat
Yeah, I
that.
wouldn't let it go.
I mean, I've done vitrectomy laser on it valves.
Yeah,
On hand motion. I mean, that kind of tucks the eye in. I mean, that's much for your patient,
yeah.
but you can do that. So central vein and iris, okay, so it's interesting. So in the studies, and I don't know, you kind of need to know this a little bit. The big thing that differentiates ischemic from non-ischemic is an APD. So if you want to, you can look at all the pictures, you can do everything else. Vision's of some importance, but the APD is more important. And the hard part in the studies, what they set up risk APD. I think the central vein occlusion study, I think some of the anti-VEGF studies.
Yeah, sometimes you can sneak them in even with the APD.
Yeah, they wanted a certain level APD, so the APD is important. So and also you should look at the iris for neovascularization. So central vein occlusion is important to examine them undilated. So risk factors for anterior segment NV is far visual acuity and non-perfusion in blood, but also APD. Causes, if they're over 50, I don't work them up. If they're under 50, we work them up for hypofibril states. Not that we do anything. And then also, it's interesting, diuretics and that. So oral contraceptives and diuretics. And that's one of my understanding, and I dug into this about 2 or 3 years ago, is if you're looking for a hypercoagulable state, which you're not going to treat anyway, the only thing you would do is stop oral contraceptives if it was a female. And that's about it. It's interesting. Because it increases the risk a little bit. And then differential diagnosis of central vein is hyperviscosity retinopathy and dysproteinemias. Evaluation, you want to look for ischemic versus non-ischemic. Age less than 50, you do that, and then central vein occlusion study. All right, so central vein occlusion study for conversion from non-ischemic to ischemic, that's what I was looking for. 16% at 4 months and 34% at 6 months. So there are people who will start okay and get worse, so you do need to follow them periodically. And then the other thing they kind of hinted at in the central vein occlusion study is if, and again, this is a little weird with the anti-VEGFs, but if someone comes in with central vein occlusion, the high risk time for developing neovascular glaucoma is the first 6 months. Once they make it past that, it's unlikely to happen. What we're stuck with now is if you have, and this is not studied, but if you have somebody with central vein, you've been doing anti-VEGFs, if you look at, there was a 4-year study, I quote it all the time, I don't know who did it, but there was a study that showed after 4 years, about 40% of central veins and 60% of branch veins no longer needed therapy. So there are people with anti-VEGFs who don't need ongoing therapy after about 4 years. So then you get a central vein occlusion, their macular edema is gone, their vision's whatever, 2200, who knows, but you're tapering them off the shots. Then you stop the anti-VEGF, then the clock starts for neovascular lacing. So then you should see them every 6 months. So whenever the anti-VEGF stop, or when they first get it, if they're not getting treated. Macular laser was shown to be ineffective with the central vein occlusion study. Branch vein it was. PRP, they said not to do prophylactic unless there's neovascularization. And then they liked vitrectomy for vitreous hemorrhage.
Which is kind of different than what you originally said in one of the first studies that you said if there was enough like 10 disc
Yeah,
areas
non-perfusion
of
to laser.
non-perfusion to laser. But
Right.
then I've always heard this, don't
Yeah.
laser unless there's,
Right. They're high risk. I think they're high risk for that. They're considered ischemic. And yeah, so, but for the central vein occlusion, essentially that was Clarkson, the old dean of chair of Bascom dean at Miami, was the head of the CRVO study when I was down there. So we talked about it a lot. And then there are a bunch of other things that have been done, which I guess, I've done all these things.
You did the Ron, we had a Ron knife somewhere?
Yeah, we had a radioactive
Radioactive
neurotomy.
neurotomy.
It was kind of cool. I did peripheral laser. I actually published a paper on peripheral laser anastomosis.
A
which I thought
Ron was a cool procedure. You would take this funky knife, a guy named Premchek developed it. It was I remember this was.
You can use the MBR blade.
You could use the MVR blade, you didn't have to use the Oprem, then you would take it and you would stick it in the nasal side of the optic nerve all the way until the diamond disappeared, right?
Whoa.
Deep into the
Yeah, you
nerve.
go parallel with the nerve fiber layers. You would go nasal on the optic nerve, do a vitrectomy, and then just nasally optic nerve, you just shove it right into the nerve, and then you pull it out. And the idea was you would decompress the nerve from the inside, And it was interesting because it's the
Did it work?
results. It kind of worked. The results of the papers were good, but then it turned out if you looked at them carefully, you were probably helping create a chorioretinal anastomosis. So it's probably not that you were decompressing the nerve, it was probably that you were helping collateral circulation to grow because you were disrupting it so much, a scar would grow.
And additionally, most of the papers, the protocol for the surgery included intravitreal Kenalog at the end, and then you would look at them 3 months after and there'd be this Kenalog effect. But I never saw one actually. I saw videos of one. I did see when I came to practice, I saw you had done some of the laser anastomoses with that big.
Oh, yeah, those are fun.
the big holes.
There's a guy in Australia.
Yeah.
It was a clever idea for laser. It was one of the first new applications of laser, but the idea was you would do a hop, again, like a hop, which you can't even get with a new laser. You turn a laser all the way up. And our little lasers are really strong. And, well, they're going on Amazon now, probably. Just to get a laser pointer from China. And you do it, and you laser an artery, you laser a vein, and you try to get the vein to bleed. And what I found was interesting, if you chose a vein that was near a choroidal vein, and then in a minority of cases, but it would happen, an anastomosis would form, a chorioretinal anastomosis between the retinal vein and the choroidal vein, and the vein occlusion would get better. The flow would just dump out the anastomosis, which was kind of when we had no other treatment. I thought it was a pretty cool treatment. Turned out in diabetics, it was a bad idea. Weird things would happen. And then they get neovascularization, and also in the absence of the PVD, sometimes you get a fractional detachment, but
I remember I was training while we were learning to use anti-VEGFs, and there were all these things for CRVO, and one of my mentors, I forget who it was, told me something that stuck with me, that's if there are a lot of treatments for something and none of them are good. And
once penicillin comes along, once there's definitive treatment, all the little treatments go away.
that's why we just get shots now, they're pretty good.
So that's intravitreal. So intravitreal anti-VEGFs, first line of treatment now, then intravitreal corticosteroids and systemic anticoagulant, which is not recommended. There's a lot of studies, the Bravo and Cruz were the Lucentis studies, about 50% of patients. Now, this is interesting, the numbers on vein occlusion, I don't have them in much detail, as I may, maybe in the future, I'll juice this up a little bit. But the visual improvement for vein occlusions is not as striking, I think, as it is for macular degeneration and for diabetics. Is that true, David? I think it is. If you look at like the 15 lines, so here are the
line gainers.
yeah, the 15 letter gainers. So they had 50% of patients gained 15 letters in the Bravo and Cruz
It's most
study.
dramatic with the RVOs.
Yeah.
Yeah.
I think it's less. I think it's a little less.
Well, I think I think it's rapid and dramatic, but they lose a lot of it.
It's rapid, but I think the end thing is.
The end
Oh,
of
that's
the-
true. No, this is better than macular
And
degeneration.
usually I can't remember because the old endpoint was 15 letter gainers, and now it's mean acuity gain. I have to look up the curve for that, but the diabetics are usually 8 or 10 letters.
Right, okay, so vein occlusions can do very well. So Bravo and Cruz, 50% of people gain 15 letter ETD outside, which is great. aflibercept was equivalent, and then there was another study showing Avastin was inferior to aflibercept and Lucentis on visual acuity measures, so it's not as good. But then there's other studies that have shown them to be equivalent, and then just in 2023, October 26th, the Balaton and Camino studies showed that the Vabysmo was as good as aflibercept. Were we in that study?
Yeah. We enrolled both of the, yeah.
I just give it shots.
Yeah.
Do
You sent in the patients in here.
yeah, send the patients in. What was the interval less on that?
No, it was interval was less what they would do. They did, that's why the label on it is weird. It was a 6-month primary endpoint. They would load and then they would treat and extend them, and it seems to be less than a year, but the primary endpoint was 6 months. Primary endpoint for all the vein occlusion studies is 6 months.
I wish I could do a 6-month study. Corticosteroids do work for vein occlusion, but they increase the IOP. The squirrel trial showed that triamcinolone was equal to laser, which is old, and then Ozurdex and ranibizumab were pretty good at 3 months, but at 6 months, the Ozurdex wasn't as good as the Verisol. But those are options. So that's all vein occlusion. There's a lot to cover. We're going to do ocular ischemia and artery occlusion too. So ocular ischemic syndromes when your circulation's bad and your eye starts to get weird. So chronic severe hyperperfusion, chronic obstruction of the brain. Basically, you don't see this very much. I've seen probably 10 in my lifetime, but it is there. A gradual vision loss, the eye kind of aches. If you see, sometimes it looks like uveitis, the eye's kind of a little bit inflamed. Sometimes the cornea looks a little bit off. 2/3 of the eyes have neovascularization and 1/5 have uveitis. Only half of the eyes with neovascularization have the pressure rise. So if you have like a rubiosis and what should be neovascular glaucoma without neovascular glaucoma, that's usually bad. It means it's kind of a sick eye. They can come in with retinal hemorrhage, like vein occlusion. They come in with vitreous hemorrhage, and then a fluorescein angiogram will show delay filling. And this is one case where ophthalmodynanometry can be helpful. And I actually do this. So what you do this when you have a free time is you can hold when you get good at it, you can hold your fundus lens and you can actually use a finger to push on the eye and occlude the central artery. And if you have a patient, if you're in try it on a patient just to see, it takes a fair amount of pressure to occlude the central artery. And you can do it on each other or whatever. But you can push on the eye. So it's nice to get a feel for that. And then if you get one of these ocular ischemic syndrome, you just kind of tap on the eye a little bit and it occludes. And I think that's one of the nicest tests to do. And then you can of course do carotid ultrasound. This is the 21st century. Usually it's atherosclerosis, your carotid is occluded. 90% or greater occlusion of the ipsilateral bladder. I find almost all my ocular ischemics are 100% occluded. So they're usually 100% occluded on the same side. The prognosis is not very good, and the treatment is to fix the carotid, but if it's totally occluded and they don't fix it. We can do PRP. I find most of the eyes just don't do well.
If they're not fully occluded and they get a carotid endarterectomy, oftentimes you have to watch them really carefully after that because they'll get more perfused and then their pressure might spike.
Right. Yeah. So you can get a sort of ischemia reperfusion injuries. So that's ocular ischemic syndrome. It's just something to keep in the back of your head because sometimes you'll get a person that's confusing. I mean, one of the things that I get confused with are recurrent vitreous hemorrhages. You'll get somebody with a pretty normal looking eye, recurrent vitreous hemorrhages, and sometimes it's ocular ischemic syndrome. The other thing I don't have here is the fluorescein will sometimes show. Fluorescein will sometimes show the horizontal raphe. Horizontal raphe will look kind of funny temporally in ocular ischemic syndrome. You get like a non-perfusion wedge because it's a watershed zone and some hemorrhages off temporally. I don't know.
So they kind of associate this with GCA, but how kind of like is it that the GCA can cause?
Yeah,
Okay.
I've not seen that. So it's true, it's on the list. But yeah, I've not seen GCA. Which it's interesting. I guess it would mean that your carotid's open, right? And you're getting inclusion of your ophthalmic artery. Because your carotid, GCA is not going to get your carotid. So it's going to get your ophthalmic artery. But it's including it enough to cause ocular ischemia without actually causing an ophthalmic artery occlusion. So it's like threading that needle. Mm-hmm. Yeah, that's it. But it's true, I guess, in a test situation. This is right out of the book. So I try to stick to the book. So GCA is a risk for ocular ischemic syndrome. Arteriocclusive disease, you've got retinal arterial obstruction, you've got branch artery occlusion, ciliary retinal artery occlusion, paracentral acute middle maculopathy, central artery occlusion, ophthalmic artery occlusion. So you got all sorts of, so cotton wool spots are just the neurofibrillary layers. You get the radial peripapillary neurofibrillary layer, gets these little blockages. It's the radial papillary neurofibrillary layer is interesting, and it doesn't mask the most as much as your macular ones. So that's why the cotton wool spots will show up around the nerve, because that system's not as robust. You get the little infarcts, they're always in the same place. If you see cotton wool spots not where they're supposed to be, it's likely not really kind of a cotton wool spot, it's gonna be something else. And I've gotten burned. I mean, the worst one was a herpetic retinopathy. You know, that looked exactly, or I mean, I think it ended up being toxic. It was a really tough case, but it was a cotton wool spot, but it wasn't in the right place. It was just like sort of inferior to the macula, right off the arcade. I thought, yeah, it looks like a little occlusive cotton wool spot, and then I should have seen the patient back, and then they come back a month later, there's a big infectious thing there. It's being recorded, but anyway, like we can do. So the cotton wool spots tend to be around the optic nerve. According to the literature, even one cotton wool spot should be worked up. Risk factors, this is all the stuff. Hypertensive, HIV retinopathy, which you don't see as much now, severe anemia, radiation retinopathy, sickle cell, embolic disease, carotid artery obstruction, and distal leukemia. So for a workup, usually CBC, check for HIV if there's risk factors. And then the lupus is used to be the top of the line before HIV came along. So I would probably check an ANA, even though I think in general ANA is kind of workable.
Would you do a full workup even though they have known risk factors?
Like how much workup do you, if you see someone in the ED that has a cotton wool spot that like?
I would probably do the CBC. I'd probably do the CBC, make sure their blood pressure is accurately checked. I don't think I checked for diabetes. Is diabetes on here? Yeah, it's interesting. It's not really on here. Because I would check for blood pressure, CBC. I would check them for HIV if there's any question, because that's a big one. And then I would check an ANA, but I've never seen it written down. So that's kind of
Hey, Steve, can you hear me?
Oh yeah, well, you sound good.
Yeah, this is Paven.
Yeah, I recognize the voice.
So, if you have a cellophane maculopathy, sometimes you'll see a cotton wool spot within that. And
Oh, in the edges.
Pardon?
Yeah, I was thinking of it at the edges, but yeah, that's true.
And the other thing for David Eichenbaum, I was the mentor who said if there are many diseases, many treatments for disease, none of them really work.
He's gonna write a letter to the
I
editor.
want future credit, David, okay?
You were my favorite mentor, so that makes sense.
Should have referenced them. So branch artery occlusions, they tend to be embolic, cholesterol, platelet fibrin plaques, or calcified plaque. You're supposed to refer emergent to the ER for stroke workup. There's a lot of risk factors. And then ciliary retinal artery occlusion is kind of its own little thing. If you have a ciliary retinal artery occlusion with central vein occlusion, that's not uncommon. We have a case of that coming up too. And usually it's probably has to do with the hydrostatic pressure. So the pressure in the vein occlusion blocks the venous circulation. It's enough of a pressure rise to actually cause a ciliary retinal artery occlusion. And you can see them in giant cells. So the ciliary retinal artery occlusion, I would check for giant cells. Paracentral acute middle maculopathy is this new thing. Yeah. Which we talked about. This is an ophthalmologist I just saw 2 months ago who had just one little spot of paracentral acute middle maculopathy. You don't see much on the color picture. The IR does show that little brown smudge, which is right here, a little dark smudge right there. And then your OCT shows a little line. And most of the people will have a scotoma. If this line was down here, do you guys know what that would be if the line was deeper, affecting the outer retina? So it's paracentral acute middle maculopathy. It's in the middle. If it's in the outer retina,
Acute macular retinopathy?
yeah, acute macular retinopathy. So acute macular retinopathy looks exactly the same. You just drop it down to the level of the photoreceptors. My nephew had that. I don't know where it came from. So it's a deep capillary plexus blockage. Usually it's a retinal vascular disease. You see it a lot in central vein occlusion. You see it in vein artery occlusion, branch vein occlusion. If you get an isolated lesion, it can be associated with giant cell arteritis. There was an editorial on Retina just last month, I guess. This month, November 2023. It's December, last month, where they found that they quoted some studies. It was interesting that PAM was the only ocular finding in 10% of eyes with giant cell arteritis. So if you have a PAM lesion and there's not a vein, if there's a vein occlusion, it's the vein occlusion. If it's an artery occlusion, it's the artery occlusion. But if there's just a PAM lesion, you have to get checked for giant cell arteritis. So I'm trying to get the ophthalmologist to get a stent rate. He hasn't got it yet. And then, and you gotta check for carotid disease. Central artery occlusion, sudden severe painless vision loss, cherry red spot. And only 18% of eyes get 20/40 or better. Most of those have a ciliary retinal artery occlusion. I have seen some patients without a ciliary retinal artery, so with a patent ciliary, I'm sorry, this patent ciliary retinal artery usually gives you good vision. I've seen rare patients where they can get vision better.
How often are we actually sending these patients to the ER?
I now tell people they should go
We got-
within a day or two.
I got
So you send them both to the ER. You guys, what I usually do, I call the primary and see if the primary can see them within a day or so.
That's
Yeah,
better, I think.
9 times out of 10, it's after 5 o'clock.
Yeah.
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 Like, really. So I have, they don't like it, right?
And then the reason I ask is there are 2 drugs in development, one of which is going into humans that we are
Oh,
going
that's
to
right, you told me.
participate in, where you have to inject serially, like every 12 to 24 hours for and the theory is these reperfuse within 3 days. I can't find the reference on that, but both companies tell me we're dosing for 3 days because these reperfuse in 3 days. And they said they're gonna send me references on that, but for the patient to get the drug and not go blind, if the drug works, they're gonna have to come back for 3 days. Or someone someday is gonna have to go into the
Well,
hospital.
they don't usually admit it. Usually I see them in the stroke center, and they just tell them to go home, because they're just,
Yeah.
they do a CT.
But it's gonna be interesting. Sometimes they keep them.
Are they gonna do a pre-injection fluorescein to see if it's perfused already? They probably will.
Oh, yeah, yeah.
Because I'll never forget when we've been doing this, I got here when I was 32, I'm 60 now, 51. And we used to do the conference, and there was one retina person in the community, and the stuff you see is kind of funny, you just kind of chuckle to yourself and you don't say anything. And what they did was they showed a fluorescein of a patient with central artery occlusion, which was fully perfused. And then they did a tap, and the vision got better. And they were like, yeah, so I did the tap and the vision got better. I'm thinking, yeah. And so you can do a fluorescein to see if they're perfused if you want it.
Well, what's interesting is not gonna be a reading center because there's no time to turn it around, you know, if there's a reading
Also, they'll
center.
rely on us.
They're probably gonna rely on us, at least for the phase 1s and maybe the phase 2s, because we're a lot less expensive than a reading center and. You know,
But they should do, there's gotta be.
time is of the essence. There might be a rapid turnaround read, but it's gonna be interesting because these patients are supposed to get intense medical care. But if we have a drug that works someday that needs to be given for 3 days and 4 days or 2 days, they have to come back.
In the referral to the ER, referral to the ER is based on a study that came out of South Korea about 8 or 10 years ago. And what they found was people who had branch retinal artery occlusions, I think 20 or 30% of them had concomitant strokes.
Yeah, so it's in the neuro BCSC.
Yeah.
They said, up to 1 of every 4 patients with acute retinal ischemia have acute brain infarcts on either
Right.
side.
In that study, which drove me crazy to the point where I wrote a letter to the editor, the study was a retrospective study of patients who had neuroimaging and artery occlusion. So all the people who had, didn't have, so if you would get neuroimaging before the paper came out, probably on people who had symptoms, neurological symptoms. So I don't think going to the ER is necessary for branch artery occlusion, but in the current environment with all the publications and all the recommendations, you gotta send them to the ER.
They did add a parenthetical here, probably after your letter, where they said some of them have silent infarctions.
Well, yes, no, most of them are silent, yeah, but that's the thing, is if you take a retrospective study, let's say you see, 500 people with branch artery occlusions, 100 of them to get scans, 20% of those have findings. There's probably the other 400 probably didn't have findings either, even probably. So.
And the hard part about managing this is you're gonna have to rely on the patient's history, because they're like, oh, I lost vision today, but it's been gone for 3 days. There's no drug that's gonna work. They have to have lost vision like today.
Right.
It's gonna
So
be-
there's an interesting poster, I'll show you a poster in a second. So acute management of central artery occlusion, reduce the pressure with ocular massage. You can do an AC tap, it's super easy. Then there's Carbogen, there's ophthalmic artery TPA was studied in Europe, and they found it to be not better than placebo, but the non-ophthalmic artery TPA group did remarkably well in that study. And then urgent referral to the ER, and not for the eye. So the idea is you're not sending them to the ER for the eye, you're sending them because they might have had a concomitant stroke. They might need workup. Iris and NB does happen. Then 18% of cases at 1 to 12 weeks. So for these patients, you have a central artery occlusion. Central vein, you should follow monthly for 6 months. Central artery, I follow monthly for 3 months, looking for iris NB, because it's out there, which is strange. I thought this was a great poster. So this was out of Mount Sinai. This was last year's academy. So what they do at Mount Sinai in New York is they have OCT machines in the ERs. And they've been putting together a cohort. So what they're doing is scanning, and they're looking for people who had recent central artery occlusions. And this was, I looked for this, I haven't seen any follow-up on this paper, but they had 7 patients included in the study. And they did really well. If you look at the final vision in the middle, they had 2025, 2040, 2030, 2020. So they had 50% of people. No, they had more than 50% of patients, because it's 7, right? Better than 2040, which is way better than, if you looked at that other paper, they had 20% of people better than 2040. And if you look at the time, door to therapy time in minutes, it's pretty quick.
What's the therapy? This is cannulation of the.
No, this is just intravitreal.
This is just
Intravitreal.
IV.
TPA. So it's interesting, so if you were to see someone with immediate vision loss, and the time to treatment, they said was 6.5 to 12 hours to from when the onset of the vision loss was, I think. Is that right? Yeah, door to therapy time. Yeah, because the door to therapy time was less than an hour. So this was based on symptoms, like you said. So these are all, so you always wonder if someone comes in with an artery occlusion that day.
We think it's 90 minutes, but.
Yeah. But you might be able to do something. Once it's a day or two, you don't have to do anything.
And did any of those patients, did they say if anyone died of a hemorrhagic stroke afterwards?
Yeah.
No, none of these did.
None of these.
Oh, really?
Yeah, no,
That was the other
this was a
11 patients.
poster.
The 29-year-old group, too, a young person, and their vision was.
So he was 2020 also. That I would say that I would throw that one out. I would.
Oh,
It
that's
is grayed out.
Some
Yeah.
kind of
Something,
confounder,
right?
some kind of something. The
Yeah,
ER
you're right.
ER
So it's
doc
about
didn't know how
50%
to-
of people.
The ER doc didn't know how to read the OCT for that one. That
That
patient had dry eye.
Patient is NLP, they just didn't take it.
So I thought that was really, ophthalmic artery occlusions you don't see, but you do see in some. Usually it's LP or NLP vision. The the color fundus shows no cherry red spot because everything's kind of non-diffuse, so you don't see the blood there. Excuse me, internal carotid artery dissection is a big deal. Orbital mucormycosis, embolization, cosmetics, which we've talked about these cases, and giant cell arteritis. So this is where I would actually worry about giant cell arteritis more than ocular syndrome. And then arterial macroaneurysm, usually ectasia, the first 3 orders of the vessels. Okay, I gotta get going. Transverse retinal vision losses from obstruction or hemorrhage. Laser can be helpful. Anti-VEGF does help with retinal edema. There's never been a study of treatment versus non-treatment for arterial macroaneurysm, just nobody's ever done it. And when I was in training, Mary Lou Lewis was a very famous medical retina person who, if Dr. Gass wasn't there, I think would have been more famous. And she said she'd never treated a macroaneurysm. Now about better. And then Pat Rubenstein was also faculty, he always treated them. So, and there was a study out of Wills, which I can't find, which suggests that once they bleed, they don't need to be treated. That was a good study, and I gotta find that. So what I tend to do is, I'll do a fluorescein. If the fluorescein shows it's leaking like crazy, I'll treat it. If it's bled already, I tend not to treat it. I have to say, I've had some of those bleed though, so I don't know what to do. And then Dr. Paven, on the meeting owl, often warns that you can occlude them. To my knowledge, I've not caused a branch artery occlusion with laser, but it would kind of rot to take someone with an asymptomatic or minimally symptomatic aneurysm, give them a giant stitch hole for a branch artery occlusion. So that's mostly chapter. So that's hypertensive retinopathy, retinal vein occlusion, carotid occlusive disease, arterial occlusion, and macroaneurysm. It's a lot.
Wow.
And you guys will talk about it more. So if I want you guys do, I really love your presentations are wonderful. So I appreciate you doing that. All right, so let's get on to that. And Saba, I think, needs to go first, but she's got to go somewhere. Are you there, Saba?
Yes,
Okay. Let me see, let me shut myself off and I'll hand it over to you. Start yours and we'll pick someone to do discussing and get back today, which is nice. Oh, thank you.
What a cool.
Yeah, I had a great, the vein occlusion I saw today.